Hi, it's your student nurse Kim, and for today's video, we will be talking about pneumonia. In this video, our goals and objective is to primarily know its definition, its pathogenesis on how the disease developed, its clinical manifestations, its diagnostic and laboratory examinations, its treatment modalities, its medical management, its nursing diagnosis along with its nursing management, and of course the prognosis of the disease. But before that, allow me to review to you the normal gas exchange and the defense mechanism of our respiratory system. And if you want to learn more about pneumonia, please do keep on watching. The respiratory system is made up of three major parts: the airways, the lungs, and the muscles for breathing. The primary function of the respiratory system is to take in oxygen and eliminate carbon dioxide. As air enters the body through the mouth and nose, air enters the trachea, which is also known as the windpipe. From there, air enters the left and the right bronchi, going to the smaller branches called bronchioles, and finally reaching the alveoli. It is where gas exchange happens, as blood passes through the tiny capillaries in the alveolar sacs. The inhaled oxygen molecules attach to the red blood cells, which travels back to the heart and all throughout the system. And at the same time, the waste products of our body, which is the carbon dioxide, is now being eliminated. The respiratory system also do have four protective mechanisms. What are those? So first is we have the pseudostratified ciliated columnar epithelium tissue, also known as mucociliary escalator. Normally, we often inhale dust, bacteria, and other foreign objects. Hair-like cells called cilia, as well as goblet cells, can be found in the lining of the respiratory epithelium. Goblet cells secrete a viscous mucus that forms layer to trap foreign materials. Cilia then moves the mucus up and out of the lungs along with the foreign objects, where it can be expelled by coughing or swallowing. Another mechanism is the cough reflex. This reflex is very important for the reason that this protects our airways and our lungs. Any trigger or foreign materials that comes within our respiratory system may activate this reflex. Our throat and our airways are made up of cough receptors. And what do? Again, when inhaled a trigger, these cough receptors recognize the intruder. And going back to the mucociliary escalator, this intruder gets stuck in the mucous lining in the airway and now will be expelled through coughing. Next mechanism is the IgA antibodies. So these antibodies are commonly present in the lining of the mucosa of the respiratory tract, and it can also be present in the GI tract and genitourinary tract. So what these antibodies do is that it binds on certain foreign bacteria or pathogens and trigger the immune system. So later on, we will be talking on what will happen during a inflammatory response. Lastly, the alveolar macrophages. So what do? So any trigger that comes within our respiratory system, these alveolar macrophages phagocytose and engulf foreign matter such as bacteria, and in response to that, it releases cytokines to pull other immune system cells to come and digest and break down those pathogens as well as trigger the immune response. So now we are already done talking about the normal gas exchange that is happening in our respiratory system, including its defense mechanism. Now let's talk about pneumonia. So what is pneumonia? So, pneumonia is the inflammatory process involving the terminal airways and alveoli of the lungs caused by infectious agents. So, to make it more simpler, pneumonia is the inflammation and infection of the lung parenchyma, specifically the lung tissue. Classifications of pneumonia. So pneumonia are classified according to its etiologic agent. So first is we have the community acquired pneumonia. The second one is the hospital acquired pneumonia. Next is the pneumonia in the immunocompromised host. And last one is the aspiration pneumonia. For the first classification of pneumonia, which is the community-acquired pneumonia, this occurs either in the community setting or within the first 48 hours after hospitalization or institutionalization. The need for hospitalization for community-acquired pneumonia depends on the severity of the pneumonia. The causative agents for community-acquired pneumonia that requires hospitalization are most frequently the streptococcal pneumonia, specifically the Streptococcus pneumoniae, Haemophilus influenzae, the Legionnaires disease, specifically the Legionella pneumophilia, Mycoplasma pneumoniae, viral pneumonia such as cytomegalovirus, herpes simplex virus, adenovirus, and respiratory syncytial virus. And lastly, the chlamydial pneumonia, specifically the Chlamydophila pneumoniae. Another one is the hospital-acquired pneumonia, also known as nosocomial pneumonia. It is defined as the onset of pneumonia symptoms more than 48 hours after admission in patients with no evidence of infection at the time of admission. Ventilator-associated pneumonia is considered a type of nosocomial pneumonia that is associated with endotracheal intubation and mechanical ventilation. This type of pneumonia is defined as bacterial pneumonia that develops in patients with acute respiratory failure who have been receiving mechanical ventilation for at least 48 hours. Certain factors may predispose patients to hospital-acquired pneumonia because of impaired host defenses, such as severe acute or chronic illnesses, a variety of comorbid conditions, supine positioning and aspiration, coma, malnutrition, prolonged hospitalization, hypotension, and metabolic disorders. Hospitalized patients are also exposed to potential bacteria from other sources, such as respiratory therapy devices and equipment, transmission of pathogens by the hands of healthcare personnel. Numerous intervention-related factors also may play a role in the development of hospital-acquired pneumonia. For example, therapeutic agents leading to central nervous depression with decreased ventilation, impaired removal of secretions or potential aspiration, prolonged or complicated thoraabdominal procedures, which may impair mucociliary function and cellular host defenses, which is very important. The tracheal intubation, prolonged or inappropriate use of antibiotics can lead to resistance of bacteria, use of nasogastric tubes. The common causal organism responsible for hospital-acquired pneumonia is first the pseudomonal pneumonia, specifically the Pseudomonas aeruginosa. So this occurs in patients who are debilitated, those with altered mental status, and those with prolonged intubation or with tracheostomy. Another is the staphylococcal pneumonia, specifically the Staphylococcus aureus. This can occur through inhalation of the organism or spread through the hematogenous route. It is often accompanied by bacteremia and positive blood cultures. Specific strains of staphylococci are resistant to all available antimicrobial agents except for vancomycin. Overuse and misuse of antimicrobial agents are major risk factors for the emergence of these resistant pathogens. Another one is Klebsiella pneumonia, including other gram-negative organisms, not to mention the E. coli, the Proteus, and the Sriracha. So next is the pneumonia in the immunocompromised host. This includes the pneumocystis pneumonia, fungal pneumonias, and Mycobacterium tuberculosis. Pneumonia in the immunocompromised host occurs with the use of corticosteroids or other immunosuppressive agents, chemotherapy, nutritional depletion, use of broad-spectrum antimicrobial agents, acquired immune deficiency syndrome or AIDS, genetic immune disorders, and long-term advanced life support technology or mechanical ventilation. For the last one, which is the aspiration pneumonia, this refers to the pulmonary consequences resulting from entry of endogenous or exogenous substances into the lower airway. The most common form of aspiration pneumonia is bacterial infection from aspiration of bacteria that normally reside in the upper airways. Aspiration pneumonia may occur in the community and at the same time in the hospital setting. Common pathogens include the Streptococcus pneumoniae, Haemophilus influenzae, Staphylococcus aureus. Substances other than bacteria may be aspirated into the lungs, such as gastric contents, exogenous chemical contents, or irritating gases. This type of aspiration or ingestion may impair the lung defenses, and we don't want that to happen because it causes inflammatory changes and lead to bacterial growth and resulting to pneumonia. Risk factors for pneumonia include travel or exposure to certain environments and residence in a long-term care facility. After a viral illness, certain underlying disorders such as heart failure, diabetes, alcoholism, COPD, and AIDS. Staphylococcal pneumonia. COPD, specifically the pneumococci or Haemophilus influenzae. Cystic fibrosis, specifically the Pseudomonal and staphylococcal organism. PCP has been associated with AIDS. Community-acquired pneumonia, including intergram-negative bacilli and Staphylococcus aureus. Now for the pathophysiology, there are two main ways on how we acquire pneumonia. The first one is through inhalation in any form of pathogen. Another is aspiration, where it could be probably due to a relative large amount of material from the stomach or mouth entering the lower airways. When that happens, ideally our defense mechanism starts working as mentioned a while ago, the cough reflex, the mucociliary escalator, the antibodies, and alveolar macrophages that helps destroy and expel the trigger. That is why this defense mechanism is very important. Once this normal mechanism is altered or destroyed, what happens is that pathogens and other foreign materials can easily enter the lungs, and we don't want that to happen. So assuming that bacteria is our causative agent here, and I know that there's a bunch of pathogens that can cause pneumonia, but take in mind that bacteria is the most common. What does this bacteria do is that it releases different types of endotoxins, and this endotoxin starts producing tissue damage. When tissues are damaged, normally chemicals are being released in response to tissue damage. So what are these chemicals? So first is we have the leukotriene B4. This leukotriene B4 goes to the circulatory system and acts as a chemotaxis that draws WBC and other immune system structure where infection is occurring. It is very important to fight back the infection. Also, bacteria have particular amino acids that we don't have. So humans do have methionine, and bacteria has this informal methionine. What does this informal methionine do is that it also goes to the circulatory system and cause chemotaxis. Another chemical that is released in response to tissue damage is the leukotriene C4, leukotriene D4, and leukotriene E4. And what they do is that they start binding on these different endothelial cells, and that causes to increase the capillary permeability. When there is an increased capillary permeability, more fluid starts leaking out, and as fluid starts leaking out, we start experiencing edema, and at the same time, pneumonia starts to occur. Another thing that happens when there is tissue damage, it activates mast cells, which is called histamines. Histamines causes blood vessels to dilate, and at the same time, it causes to increase the capillary permeability. And when this happens, WBC, Complement proteins and other immune system structure begins to be drawn where the inflammation is happening again to fight back the bacteria. Another thing that this leukotriene C4, D4, and E4 do is that it binds in respiratory muscles. And when it happens, it causes bronchospasm. And when that happens, we start experiencing dyspnea or shortness of breath. I just want to add that it was mentioned a while ago that alveolar macrophages are part of the defense mechanism and its role is to engulf the bacteria, and these macrophages release chemicals such as interleukin-1 and tumor necrosis factor alpha. Both of them is very important because this also increase the capillary permeability and also induce pyrexia. That is why when a patient experiences pneumonia, it usually manifests fever. In continuation, pneumonias have 4 stages. Number 1 is the congestion. This stage occurs within the first 24 hours after contracting pneumonia. During congestion, the body will experience vascular engorgement, intraalveolar fluid, and multiple bacteria. The lungs will be very heavy and red. Capillaries in the alveolar walls become congested and the infection will spread to the hilum and pleura. During this stage, a person will experience coughing and deep breathing. Next is the red hepatization. This stage occurs 2 or 3 days after congestion. At this point, the lungs will be red, firm, and airless, a resemblance to the liver. Alveolar capillaries will be engorged with blood and vascular congestion will persist. During the red hepatization stage, the alveoli will contain many erythrocytes, neutrophils, discriminated epithelial cells, and fibrin. Third stage will be the gray hepatization. This stage will occur 2 or 3 days after red hepatization and is an avascular stage. The lung will appear to be grayish-brown or yellow color because of the disintegration of red blood cells. Your lungs will also appear to be paler and drier than usual. There will be a persistence of fibrin exudate during this stage. For the last stage, which is the resolution or complete recovery, this occurs when the exudate experiences progressive enzymatic digestion. This will produce debris that is eventually reabsorbed, ingested by macrophages, coughed up, or reorganized by fibroblasts. For the clinical manifestations, patients with streptococcal pneumococcal pneumonia usually has a sudden onset of chills, rapidly rising fever for about 38.5 to 40.5 degrees Celsius, pleuritic chest pain that is aggravated by deep breathing and coughing, patient is severely ill with marked tachypnea for about 25 to 45 breaths per minute, accompanied by other signs of respiratory distress such as shortness of breath, use of accessory muscles in respiration. The pulse is rapid and bounding, and it usually increases about 10 beats per minute for every degree Celsius of temperature elevation. Another one is a relative bradycardia, a pulse temperature deficit in which the pulse is slower than that expected for a given temperature, may suggest a viral infection, mycoplasma infection, or infection with the Legionella organism. Some patients exhibit an upper respiratory tract infection, such as nasal congestion or sore throat. And the onset of pneumonia is gradual and nonspecific. The predominant symptoms may be headache, low-grade fever, pleuritic pain, myalgia, rash, and pharyngitis. After a few days, mucoid or mucopurulent sputum is expectorated. In severe pneumonia, the cheeks are flushed and the lips and nail beds demonstrate central cyanosis, a late sign of poor oxygenation or what we call as hypoxemia. Patient may exhibit orthopnea, which is shortness of breath when reclining, preferring to be propped up or sitting in bed leaning forward, or what we call as orthopnic position, in an effort to achieve adequate gas exchange without coughing or breathing deeply. Sputum is often purulent. However, this is not a reliable indicator of the etiologic agent. Rusty blood-tinged sputum may be expectorated with streptococcal, pneumococcal, staphylococcal, and Klebsiella pneumonia. For the diagnostic and laboratory procedure, first is we have the chest x-ray. So this shows a discernible infiltrate and presence or extent of pulmonary disease, typically consolidation. Second is the gram stain and culture and sensitivity test of sputum. This may be indicated to determine offending organism. Obtained in the bronchial specimen from intubated patients. Indications for sputum culture include admission to intensive care unit, antibiotic failure, cavitary lesion on chest x-ray, active alcohol abuse, severe lung disease, positive Legionella or pneumococcal urinary antigen test of pleural effusion. Third is blood culture, so this detects bacteremia, bloodstream invasion occurring with bacterial pneumonia. And last is the immunologic test, which detects microbial antigens in serum, sputum, and urine. For the medical management, antibiotics are prescribed based on gram stain results and antibiotic guidelines. Resistance patterns, risk factors, etiology must be considered. Combination therapy may also be used. Supportive treatment include hydration, antipyretics, antihistamines, or nasal decongestants. Moving on with the treatment modalities, oxygen therapy is given for hypoxemia. Most probably patient will be experiencing this. Respiratory support includes endotracheal intubation, high inspiratory oxygen concentrations, and mechanical ventilation. And additional management, for groups at high risk for community-acquired pneumonia, pneumococcal vaccination is advised. For the nursing diagnosis, first is we have the impaired gas exchange related to decreased ventilation, secondary to inflammation and infection involving the distal air spaces. Ineffective airway clearance related to excessive tracheobronchial secretions. Another is acute pain related to inflammatory process and dyspnea. Lastly, the risk for injury secondary to complications. For the nursing management, particularly in improving gas exchange, first is we should observe for cyanosis, dyspnea, hypoxia, and confusion indicating worsening condition. Second is follow ABG levels or the oxygen saturation to determine oxygen need and response to oxygen therapy. Administer oxygen at concentration to maintain partial oxygen at acceptable level. Hypoxemia may be encountered because of abnormal VQ mismatch with shunt in affected lung segments. Avoid high concentration of oxygen in patients with COPD, particularly with evidence of carbon dioxide retention. Use of high oxygen concentration may worsen alveolar ventilation by depressing the patient's only remaining ventilatory drive. If high oxygen concentration of oxygen are given, monitor alertness and partial oxygen and partial carbon dioxide levels for signs of carbon dioxide retention. Number 5 is place patient in an upright position to obtain greater lung expansion and improve aeration. Frequent turning and increased activity up in chair ambulate as tolerated should be employed. For the enhancing airway clearance, if ordered, obtain freshly expectorated sputum for gram stain and culture, preferably early in the morning specimen as directed. Instruct the patients as follows: to rinse mouth with water to minimize contamination by normal flora. Breathe deeply several times. Cough deeply and expectorate raised sputum into sterile container. Next is encourage patient to cough. Retain secretions interfere with gas exchange as mentioned a while ago. Suction as necessary. Encourage increased fluid intake unless contraindicated to thin mucus and promote expectoration and replace fluid losses caused by fever, diaphoresis, dehydration, and dyspnea. Next is humidify air and oxygen therapy, which may loosen secretions and improve ventilation. 5 is to employ chest wall percussion and postural drainage when appropriate to loosen and mobilize secretions. Auscultate chest for cockles and rhonchi. Administer cough suppressants when coughing is non-productive, but only if there is no evidence of retained secretions. Mobilize patient to improve ventilation and secretion clearance and reduce risk of atelectasis and worsening pneumonia. Moving on with the relieving pleuritic pain. First is place patient in a comfortable position, semi-fowlers for resting and breathing. Encourage frequent change of position to prevent pooling of secretions in lungs and atelectasis. Next is to demonstrate on how to splint the chest while coughing. Avoid suppressing a productive cough. Administer prescribed analgesic agent to relieve pain. Use opioids cautiously in patients with history of COPD. Gerontologic alert. Sedatives, opioids, and cough suppressants should be cautiously in elderly patients because of their tendency to suppress cough and gag reflex and respiratory drive. Also provide or encourage frequent oral care for pneumonia prevention. 5 is to apply heat and or cold to chest as prescribed. Assist with intercostal nerve block for pain relief. Encourage modified bed rest during febrile period. Watch for abdominal distension or ileus, which may be due to swallowing of air during intervals of severe dyspnea. Insert a nasogastric or rectal tube as directed. Monitoring for complications. Number 1 is to remember that fatal complications may develop during the early period of antimicrobial treatment. Monitor temperature, pulse, respiration, BP, oximetry, mentation, and for evidence of dyspnea at regular intervals to assess the patient's response to therapy. Auscultate lungs and heart. For heart murmurs or friction rub may indicate acute bacterial endocarditis, pericarditis, or myocarditis. Fourth is to employ special nursing surveillance for patients with 1 is alcoholism, COPD, immunosuppression, because these people as well as elderly patients may have little or no fever. Another is chronic bronchitis. It may be difficult to detect subtle changes condition because the patient may have seriously compromised pulmonary function and regular mucus production. Next is epilepsy. Pneumonia may result from aspiration after a seizure. And for the last one, delirium may be caused by hypoxia, meningitis, delirium tremens of alcoholism. Nursing alert. Delirium must be controlled to prevent exhaustion and cardiac failure. Prepare for lumbar puncture if indicated to rule out meningitis, which may be lethal. Mild sedation should be considered with caution. Fifth is to assess these patients for unusual behavior, alterations in mental status, stupor, and heart failure. And last one is to assess for resistant fever or return of fever, potentially suggesting bacterial resistance to antibiotics. The prognosis of pneumonia is usually good for people who have normal lungs and adequate host defenses before the onset of pneumonia. However, bacterial pneumonia is the fifth leading cause of death in debilitated patients. So that ends my video presentation today, and I hope you guys learned something, and thank you so much for watching.